Thank you very much for the introduction. First, I'd like to thank the organizers for letting me have the honor of presenting the work of my colleagues at King Fahd Specialist Hospital. So, agenda of my presentation, first a brief introduction, then, basic literature on cryopreservation versus non-cryopreservation, and some historic data, then data of the patients with multiple myeloma who have received auto-transplant at our institution over the last 11 years and 3 months, and then short and long-term outcomes of these transplanted patients. Finally, I will come to the conclusions. If there is time, I'll go for appreciations. So, as you are aware, since the mid-1990s, high-dose chemotherapy followed by auto-transplant has become the standard of care for patients with newly diagnosed multiple myeloma who are transplant eligible. Cryopreservation is routinely practiced in the setting of auto-transplant. The long-term outcome of multiple myeloma subjected to auto-transplant has improved over the last 3 decades due to the progresses in patients' care. I found actually one excellent long-term outcome on multiple myeloma. Nishimura et al. Reported the long-term outcome of a total of 4,300 and almost 30 patients with newly diagnosed multiple myeloma treated with autologous transplant at the University of Arkansas in USA between the years 1989 and 2014. Of course, they were using cryopreserved stem cells. In that study, the 5-year overall survival was 47 to 70%, and the progression-free survival was ranging between 29 and 68%. This is the progression-free survival, where you see the 5 years, in the year 1989 was 29, and going to much higher to 68% in 2014. This is actually the graph A represents the overall survival of these patients. So just to get you back to the situation where we had at King Fahd Specialist Hospital just before starting our transplant program. Possibly our colleagues working in Riyadh know that 20 to 25% of the recipients of transplant in Saudi Arabia come from the eastern province, so the demand that time was very high. Our institution became partially operational at the end of 2006, but plenty of the infrastructure was lacking. So with interest, we carefully read the experience of stem cell transplanters working at various cancer centers which lack cryopreservation facilities. And we found out that their arrangements for transplantation and even their results were almost the same. This was reflected by large studies and major reviews published. After making sure that performing auto-transplant without cryopreservation is safe and doable, we did actually validate the viability of stem cells from samples of apheresis taken for our patients who were sent that time to King Faisal Specialist Hospital. And we also validated CD34 enumeration. So these are important landmarks in the history of transplant without cryopreservation. Studies have shown that peripheral stem cells can be stored in the routine fridge at 4 degrees centigrade for 5 days without significant loss of viability. Thereafter, the viability decreases progressively by 10% each day. Milfalan, there's another issue, which is still the standard of care as a conditioning therapy for multiple myeloma, is cleared from the plasma within 1 hour and from the urine within 6 hours after IV administration. So the technique is of value in two scenarios in medical institutions like ours, in the process of establishing stem cell transplant but lacking cryopreservation. So these are the major advantages and disadvantages of non-cryopreserved stem cell transplantation. Without cryopreservation, actually, the advantage is mainly simplicity, and after that, this can allow transplant as outpatient, a reduction in cost, a reduction in time, prevention of DMSO toxicity, and no significant loss of viability, unlike in cryopreservation. The main disadvantages are plenty of coordination between various teams is needed and inability to store part of the apheresis if a rich yield is obtained. So even non-cryopreservation was, available at least in the preclinical studies since the year 1957. After that, even 3 major studies performed in the West showing that overnight storage of autologous stem cells compared to cryopreservation had no significant difference between the two groups regarding viability, neutrophil or platelet engraftment, safety, or even long-term outcome. Even they found the same findings that this reduces cost and processing time. So back to our institution. Day 0 of our transplant, as I mentioned, we had no cryopreservation facilities. There was 1 permanent consultant, 1 part-timer, and 1 locum consultant. No single nurse in the hospital with transplant experience, no irradiation of blood products, and our infrastructure was being built. So just coming directly to the main findings, over the last 11 years and 3 months, we did perform 135 auto-transplant procedures for 119 patients. Well, the rest, 12 patients had planned tandem auto-transplants, and 4 others received second auto-transplant after relapse and progression, of course, after controlling their disease progression. The median age of our patients was 51.5 years, almost 15 years younger than that in the West. At presentation, our transplanted patients had significant, high-risk features. The revised international staging index, stage 3, extensive bone involvement, and adverse cytogenetics. As well, we had less than 10% having significant renal dysfunction or even end-stage renal failure. Over this time, we managed to transplant almost 79% without cryopreservation and 22 with cryopreservation. Almost 47% of our transplants were performed in the outpatient setting, while 53 were performed as inpatient. So, alhamdulillah, despite all the difficulties, the 100-day survival for our patients transplanted as inpatient or outpatient was 100%, and this is actually reflects the great care displayed by our medical and nursing staff. The 4-year overall survival and progression-free survival for patients with multiple myeloma who received fresh cells were 82 and 68 respectively. And we think that this is one of the best world figures. Alhamdulillah. Okay, so regarding the stages, almost 47% 40% of our patients were stage 2 and 3. Cytogenetics, more than 40%, they had adverse cytogenetics, chromosome 3, 17p deletion, translocations involving chromosome 14 apart from translocation 614, which implies good prognosis and monosomies. Unfortunately, we had most of our patients having extensive bone involvement with lytic lesions, pathological fractures, osteopenia. Well, we had 6 patients with end-stage renal failure on dialysis, 4 patients not on dialysis yet, and we had 8 others with creatinine clearance ranging between 20 and 30. So the regimens used, well, mainly Velcade-based therapy, and well, initially we used Velcade-Dexa alone, like possibly most of the institutions. Then we moved to the triplet regimens, and VRD is still the backbone of our treatment. Number of lines given, well, alhamdulillah, almost 3/4 had only 1 line. More than 3 lines, less than 10%. Type of response achieved before auto-transplant, 60%, they had very good partial response, and less than 1/3 of patients had complete response. The stringent complete response was achieved only in 1.5%. Regarding maintenance therapy, well, like other institutions, initially we were using thalidomide alone for 1 year, then 2 years, then Velcade came. Then after almost 2015, we started giving maintenance till disease progression for standard risk Revlimid and for high risk Velcade. So more than 50% of our patients have used this continuous progressive therapy. Regarding neutrophilic engraftment, as you know, we give G-CSF on day 5. The median day of engraftment was day 11, for platelets, day 17. The main complications encountered in the early pre-transplant period were mucositis, engraftment syndrome in 1/4 of our patients, and febrile neutropenias. Well, engraftment syndrome, I just like to elaborate here. Manifestations like those of acute GVHD, but milder. Main risk factors, heavily pretreated patients, second autograft, and high stem cell dose. However, we encountered 2 severe forms that needed a short cycle of steroids. And one of them, the second one, had capillary leak syndrome after ruling out cardiac and lung issues, and he was about to go to ICU. Only after giving him steroids, things were reversed. Outpatient autotransplant, I'll just elaborate a little bit on that. Since August 2016, we've done 63 transplant in the outpatient setting. Also, we do at our institution autotransplant in the outpatient for Hodgkin disease. We've done 32 so far. Main inclusion criteria are actually presence of caregiver who can bring the patient to hospital at any time, living nearby within maximally 30 minutes from hospital. Candidates actually for autotransplant are treated the same way, with the difference that they have to come daily to the treatment area to have their labs and to have clinical evaluation. We encourage the caregivers to bring them to ER in case they notice any complications, and our on-call physicians are instructed to admit these patients whenever they have complications. By the way, 25% of our patients get admitted for a day or 2 because of mucositis and possibly fever. So, for patients with renal dysfunction, as I elaborated the numbers, the main differences, number 1, to modify the doses of medications according to creatinine clearance, administering chemotherapy after hemodialysis, and including milfalan. The doses of milfalan we used were ranging between 140 to 200 milligram per meter square. And one important thing is to give the stem cells after dialysis, otherwise you may lose them. This is actually our long-term data. This is the overall survival for the entire group. The 5 years is almost 75%, and the progression-free survival is in the region of 60%. And see here, one important thing is that, well, even at 11 years, the overall survival is still around 60%. Here, possibly, this is the most important slide for us, just to show you for fresh cells, the patients who received their autografts without cryopreservation. See, the 4-year overall survival is 82%, mashallah, and the progression-free survival 68. And see the same pattern. Possibly, if they exceed 10 years, they may die of other medical causes. A progression-free survival for inpatients compared to outpatient, well, initially the curves will overlap, then they diverge, but the difference between the two is not statistically different. For overall survival, the curves diverge early, but still the difference is not statistically significant. Here, yesterday we heard a lot about role of maintenance till progression using multiple agents and continuous therapy. Just here, we are not hiding our data, number one. Number two, we like our colleagues working at other institutions to look into their data. We've seen a disappointing result after applying this, maintenance therapy till disease progression and continuous therapy. See here the difference. Those transplanted before 2015, their overall survival and progression-free survival were 66 and 60%, while those transplanted after, this is progression-free survival, the 5 years and 8 years, and those transplanted after 2016, the percentages dropped to 51 and 45 respectively. Overall survival as well, there is a significant difference there. See, the picture becomes much clearer if you compare those transplanted before 2017 compared to those transplanted after that, and see the progression-free survival dropped from 65 to 46%, and the overall survival dropped significantly from 76 to 45% with highly significant p-value. So with my respect to everything, we have to examine our own data. Okay, examples of outstanding cases we treated and we reported at our institution. In 2011, we had a young patient with multiple myeloma, refractory to 4 lines, then responded to 5th line. As he had end-stage renal failure, we offered him renal allograft. He's still alive. In 2012, a year later, same story, end-stage renal failure, but insulin-dependent diabetes. The important thing is that after day 100, the patient needed 0 unit of insulin. Till now, over 10 years, his insulin-dependent diabetes has been cured with autotransplant. Another one, 2016, plasma cell leukemia, cured with tandem transplant followed by autotransplant. This is no time for a difficult case who failed even allogeneic transplant and tandem transplant. In conclusion, so autologous transplant without cryopreservation is safe, feasible, and leads not only to excellent short-term outcomes, but also to long-term outcomes that are comparable to the standard autologous transplantation with cryopreservation. So for us, even after having cryopreservation facilities installed at our institution about 10 years ago. The excellent outcomes encountered encouraged us to continue offering at least the first transplant in myeloma with fresh cells. Fresh cells as well allowed us to perform almost 47% of our stem cell transplantation as outpatients, thus reducing costs and saving beds. Multiple myeloma with in patients with end-stage renal failure should not be excluded. Particular attention should be paid to dose adjustment and the timing of administering stem cells. This is first transplant. This is the celebration we had. This is the short stay outpatient transplant. These are our consultants, coordinators, nursing, and we thank everybody who has been involved in this great work. Thank you very much.